Oh, hey, Chris.
Hey Chuck, how are you?
I'm good. How are you?
I'm good. It's Friday morning. We're recording, and we're both excited about a fun day of activity and fun weekend coming up.
Yeah, what you got going on today?
I'm doing a clinic, and then we're traveling for the weekend. It'll be fun. I'm excited about it. But my wife is on this amazing thing of wanting to do all 50 states before the kids graduate high school. So we'll be checking off Nevada this weekend.
Oh my God, that's so funny. So you guys will get out there, hike around, see the sights, and get back on a plane.
Yeah, basically. But I'm not making them do a PowerPoint at this point, so. Let
Chris
me
is
take
a
a
li
play out of the Gold Farm playbook at some point in the future and make them sing for their supper, so to say.
one day, but that was only for major international excursions.
Ah, okay, that's good to know. Okay, now next time we go international, I'll let them know. So
Yeah.
you're busy with school today and tomorrow?
Yep. School Thursday, Friday, Saturday. So day two today, which is Friday the 30th before Labor Day weekend. And this episode will drop on the 8th of September. So yeah, another school day and continue to enjoy it and power through.
Excited about today's episode. We've gotten some great listener emails, so please continue to email us your thoughts and ideas and feedback and corrections, including something that we'll talk about today. So handpodcast@gmail.com. Speaking of corrections, I was called out by our fellows for misquoting some anatomy numbers in conference.
Ouch.
Were you there on that day? I think
I
you were
was there,
present.
but what
We
did
were
you
talking
misquote?
about the absence of an FDS in the small finger. And I had a number in my head that turned out to be incorrect. The number that our fellows found was also incorrect. So, a shout out to our fellows, Dan Hong, Nick Collada, and Eric Jang for calling out their fellowship director for misquoting something. So I actually had to go back and I screen capped my fellowship notes from when I was a fellow. I was like, I consider that to be the standard.
The source.
The arbiter of truth is from when I really knew the numbers as a fellow. The point was that not everybody has an FDS to the small finger.
And what is the number of those who do not?
The number I have is 20%, an actual anatomic absence. Now, in that book that you co-edited, and it's a lovely book. Every hand fellow should have a copy of it. I received no royalties from shouting out Chuck's book, but Primus Manus.
I receive barely any royalties.
I don't see that book listed on your disclosure, by the way, Dr. Goldfarb. Primus Manus. It's an awesome anatomy resource. I believe it was you, Marty, and Fraser Leversedge. Fantastic anatomy book. Our fellows and residents know about the Word documents that have all the numbers. All the numbers typically come from that book, or the book has all the numbers from the anatomy handouts, either way. Um, but in that book, it's listed as up to 75% may have a discrepancy in being able to functionally differentiate the FDS from the FTP to the small finger.
Up to 75%.
Yeah, I believe it's 75 or 70. I can't remember the exact number in
Wow.
Primus Manus.
Cool.
So
Yeah,
functional versus anatomic, but all that matters is that if you go in there and you don't see an FDS to a small figure, don't freak out.
that's right. And be prepared for that when you're exploring a small finger. You know, the small fingers are the one that we wince a little bit if we have an isolated tendon laceration just because of the size. But sometimes if it's an isolated FTP, it's a little bit easier and a little bit less concerning, at least in my mind, for work of flexion after repair.
Yeah, and then speaking of flexor tendons, a bit of a grab bag episode anyway. I mean, I remember talking about an FDP zone one a few episodes ago. Uh, I let the patient keep the button. He very much wanted to keep the button to give to his granddaughter. He did he did amazingly well so far, knock on wood, but everything has gone well. So just to close the loop on that, I think we talked about that a few episodes back.
Yeah, you know that the whole keeping the stuff continues to be a question for patients, and I get it to some degree. Whether it's removed hardware, which is harder than ever at our institution, although you know sometimes it happens. And we took out a mass a couple weeks ago, which was just a fibroma, and the patient really wanted the mass, and their logic is, it's my body, it's my mass, why can't I have it? And I just have to say, because you can't.
'Cause it's gross, man. You can have it after the washy pathologist looks at it at least. Yeah,
It,
for
do-
the implant.
it won't look that good on the shelf. Uh-oh. You there?
Me or you?
It's you, I think. I'm hardwired.
Yeah. When did you get a heart?
At Talia's desk.
Oh, nice. Okay. Let me try moving really quickly. This is weird because I've done this here before. Okay, is that better?
Yeah, you're back.
You know what confuses me at times is how much they want to keep the implant. But again, I guess they've paid for it. And honestly, a recon plate makes a really sweet bracelet. I've seen it done in New York. So, hey, to each their own.
Yeah, I think the hardware removals I get a little bit more, but the stuff, and I think we may have talked about this a long time ago. In kids, sometimes if the kid gets older and the family chooses to wait to allow the child to determine whether to remove an extra digit, sometimes the child will want the digit, and that is freaky to me.
Yeah, that's something. I
Yeah,
do like showing people things that are removed, if they're awake. I do a fair number of foreign body removals of various varieties, and honestly, it took out a huge splinter that was lodged in a very uncomfortable place, and it was very gratifying. And I think uh, uh, fulfilling for the patient to know that she was like not making this up, like it was not a crazy thing.
absolutely. 100%.
All right,
Um,
let's move on to the episode.
All right. We were gonna do some grab bag, mail, or we're also gonna talk about the hand society. Which would you like to start with?
Why don't we go through some of the grab bag and we can talk about what we'll be doing at the Hand Society coming up. But first, we should thank our sponsors of Practice Link.
Absolutely. The upper lip.
The upper limb.
The upper hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician and reading copy, they're both hard. Finding the right job doesn't have to be. Join Practice Link for free today at www.practicelink.com/the upper hand. That is two episodes in a row where we have struggled with the Practice Link copy. After
It,
Dan Hong told me I could read it in my sleep, I completely flubbed it on the last one.
yeah, it should not be getting harder. We heard from Rob Gray, friend of the
Yeah.
pod.
Yeah, friend of the pod. So, Rob, we shouted him out last time when we talked with Sanj about the SL ligament, and he said that he just listened to the pod that morning. Said, "Great to hear my buddies getting all nerdy about a ligament that I'm not sure exists." Ooh, hot take, Rob. Hope you guys have a great day. Keep fighting the fight.
That's going to rub some people the wrong way. Although I kind of hear him. When you have an acute tear and you go to put a stitch in that ligament, it is just super flimsy, and I never feel like that's an effective treatment.
Yeah, I would probably say the same thing. But I'm not there enough to. I don't know if repairable tears actually exist of a ligament, which therefore of that ligament, which makes you think, is it truly a ligament? But it is a fiber structure that connects two bones, so I'll give it that.
Absolutely. All right, we have another one, which is a great question. We only have a handle rather than a name.
Ooh,
This is
let me read this one because I want you to
oh,
answer it.
okay.
So for those of you that don't know, the upper hand is also on YouTube. So make sure to check it out because this actually is our first comment that we're going to shout out from a YouTube from the YouTube channel. So this is from at James MW4SH. Thanks for your great show as always. Here in Cincinnati, the big question is, will Joe Burrow perform at the same level or better since he had his SL repaired? Can you comment on rehab and expectations for athletes who have their SL ligament repaired? Thanks and go Bengals. A number of emojis. This is relevant not only for Bengals fans, but also fantasy football. It's upon us. So, what do you think, sports expert Dr. Goldfarb?
Yeah, well, I think first of all, thanks for the question. I think it's a really good one. And in my mind, this is one of the more serious sports injuries. And the answer to the question, unfortunately, I think depends on the details. Was this an isolated SL tear? Was it a partial SL tear? Was it an SL tear in addition to the other surrounding ligaments? So the degree of the separation, the degree of the injury really, really matters. Um, when someone has a SL tear that leads to marked displacement of the scaphoid with flexion and gapping, it is a big deal repair, which at a minimum leads to some wrist stiffness. And at a maximum, leads to other problems. Now, the good news about the SL, I think most of us appreciate, is that problems typically develop far down the road, and that is arthritis. And so usually in the short term, you can regain motion, regain strength, and may have a little bit of a nagging injury, but not dramatic. But it's a problem, and I think the degree of the injury ultimately will determine how well Joe Burrow performs this year.
Got it. Okay, so great dodge, great evasion there.
Well, it
Evasive
all
tactics, almost like Mahomes in the pocket.
it also, of course, I mean, I assume this is his throwing hand because
Well, that was actually my question. I don't know if it's a throwing hand or not. And how does the football throwing motion, how does that impact the, prognosis, the rehab that you do? And then we haven't really talked about dart throwers, in the past. Is that something that you think is pertinent to this?
oh, I do think it's pertinent. And so, and I'm not an expert on the dart throwers rehab protocol, but I believe that was popularized out of HSS with Scott Wolf. And essentially, the concept is if one goes from from extension in the radial direction to flexion in the ulnar direction, it is a non-stressful motion that allows you to work on motion quickly without stressing any type of repair. That's my take on it. And I think we use the dart thrower rehab protocol, but we're not quite as focused on it here in St. Louis as other sites might be.
Yeah, no, and I wonder how much, the functional demands on the wrist of if it is a throwing hand, what implications that has. And it's always interesting, these kinds of injuries are hard for athletes to come back from. I remember there was a wave of papers and knockoff papers and knockoff papers of knockoff papers using fantasy football stats to evaluate return to play among NFL players. Same thing with fantasy basketball, et cetera. And we all know just anecdotally, like, Kobe was never the same after his Achilles. So like it's stuff like that that really gets to you. Now, I think like you said, the devil's in the details, I think, for this one.
Yeah, and I just did a quick search. It was indeed his throwing wrist, and so I'm sure he was doing a little bit of the dart throwing rehab protocol, and he's had time. So we'll see kind of how he does. The injury that worries me obviously even more is the perilunate, and I have seen perilunates in careers. Although again, it depends a lot on other factors such as what position and throwing or skilled arm or not. But that's a really big injury that we tend to see in the NFL.
Yeah, no, I would imagine that's awful. I mean, just outside of the sports population, I mean, perilunates are like the pelons of the hand and wrist. They just don't do well. And pelon being a distal tibial impaction fracture involving the joint. Those patients just tend not to do well.
Yeah, yeah. Anyways, great question. Obviously, love talking about sports. We hadn't had a sports topic in a while because we seem to always be talking about nerve. But
We have not
I
talked
think
about Nerve in quite some time, to be honest with you. I
really,
have some interesting, yeah, no, we've been doing a lot of other things. We're talking about your knee, etc. So, we have one shout out quickly, and then some great feedback from another listener. So this is from Bob Vandermark. Bob is a friend of the pod, been listening for a long time, so thank you, Bob. Um, Chris and Chuck, look at that. Not Chuck and Chris, Chris and Chuck.
come on,
Just
Bob.
finished the SL podcast with Sanj. Chris, you were so right. It was a masterclass on the topic. You could do a few more episodes for sure. Thanks for sharing. And I think I completely agree. If people want to hear more, especially if you want to hear more from Sanj, let us know and we'll get that guy back on the podcast. I feel like we barely scratched the surface on that topic.
For sure. The problem with Sanj is he sounds really smart because of the damn accent, and he makes us both sound less intelligent. So I don't know if we want to have him back on.
I am not threatened by his accent. I feel like, our American accent resonates perhaps overseas in a very different way.
Yeah, a very different way is exactly right. It's exactly right. Well, we have so that's all the comments I believe that we have on SL. And we have a bunch on the rock climbing episode.
Yeah, so this came from our listener Chris out in Washington. He actually suggested doing the rock climbing episode, so thank you to Chris for suggesting that. Um, he said that pulley ruptures definitely come up in the climbers that he see, but it's isolated to a single pulley. You get them back to climbing with non-op approaches. So I guess pearls that he's mentioned just in general from a more rehab focused perspective and less surgical is that it's hard to get climbers to rest because they really need to get them to rest, but they really do need to do that in order to heal. Thermoplastic ring splints, some available online, or having a hand therapist make one seem to be quite helpful. This is interesting. So a full A2 rupture might take 3 months to get back to full climbing, though easy climbing on big holds with an open hand grip can start sooner. Now, have you been able to hold a rock climber down for 3 months, Chuck?
Definitely not, although it depends. I think people who've had even smaller injuries before understand that this is going to take a while to get back. Occasionally people will wait, but usually they sort of just power through. And ultimately, I think they do fine. I don't think it changes the ultimate outcome. It's just how uncomfortable it is to get there.
Right, right. And I appreciate Chris giving me that number just because I think that, for the occasional climber I see, it's useful to have somebody with some expertise kind of telling them, hey, this is going to take a while. It's not going to be quick. And then he also mentions the key of finding a PT or hand therapist that works specifically with climbers, in terms of having them work on areas of relative weakness in climbing technique, because sometimes, climbers rely too much on crimp grip and they might be weak through the rest of the kinetic chain. So I find that very interesting. I don't have a lot of knowledge of that, but I think if you are seeing these folks, maybe reaching out and seeing who in the community, in your therapist community, does have experience working with these types of patients.
Yeah, it's a really good point. Like many things we do in hand surgery, we have to depend on our therapy colleagues to, consider other factors that may lead to overdependence on, in this case, the crimping technique or other strategies to overcome weakness. And then his final point is also a good one, which I have absolutely seen. Chris makes a comment um, that there is a potential for fractures in the skeletally immature. So classically, Salter Harris 3, classically base of the middle phalanx, and that can be acute, that can be chronic overuse. X-rays typically tell the story along with a careful clinical exam. Chris makes the point that sometimes an MRI can be helpful. I don't recall getting an MRI for that purpose, but I think it's absolutely fair. And those, again, just need rest to do well.
I think those are great points. Something I would not have thought of just because I don't see that population as much. So I appreciate the education from Chris McMullen. Thank you for that. A great discussion. And if anybody has any other pearls on climbing, please feel free to send those in because it feels like something that people see a lot of, but it's not generally discussed too much in the literature aside from that really nice recent article review article that we covered. I think we have one more comment from a friend of the podcast about rock climbing. So I think this is our buddy, but you know him better, Kevin Lusky.
Yeah, so Kevin was a fellow here in at WashU. Initially, he was at Rothman in Philadelphia, and he has since moved up to Vermont at the university and is thrilled to be there. Still has, I think he still maintains his academic bent, but very different lifestyle, and happy that Kevin landed where he did. Kevin's email was, I really liked your rock climbing discussion because I'm a climber. And I also recently gave grand rounds on the topic. I agree it's interesting that we spent a lot of time focused on pulley injuries, which are characteristic but so rare. So hand surgeons agree, we just don't see that many of these. Kevin said, on the other hand, overuse or semi-traumatic injuries like flexor tendonitis, lumbrical strain, capsular and pulley sprains, etc., are way more common but get a lot less focus. These may be prevented by attention to proper technique. And he says slow accommodation to harder grades, avoiding closed crimps, Spider-Man pocket grips, and not climbing through pain. Preventative taping does not seem to help in Kevin's experience. And he closes by saying, great discussion. He references a paper that he was a part of, which is published open access in Curious 2021, Time to Improvement After Corticosteroid Injection for Trigger Finger. And I think this is relevant for the treatment of climbers. And again, Kevin loves the podcast, and I definitely will see him in Minneapolis.
Yeah, no, I think those are really helpful pearls. Nothing like having a surgeon who, or not only a surgeon, but also from Chris McMullen, a rehab doc, both who are very keen into climbing, be able to give expertise not only from professional and personal perspectives. And I like the article he sent about trigger finger injection because I also found that helpful because we had that discussion during the What's New in Hand Surgery about how long it takes to get over an injection. And now that I've told patients kind of 2 weeks, I feel like some others have been like, oh yeah, it took a couple of weeks to kick in. I was like, oh, okay, good to know. I've also had a lot of people say their trigger got better with observation because it took 4 months to get in. So there's that too. And I think we should mention that Kevin does a really great job with the Hand Society Perspectives newsletter. It is a very different take on life as a hand surgeon, and you get a lot of international participants too. So I enjoy reading that, and I really wanted to thank Kevin for leading that effort and all the people that contribute to that because it's more of the from not the technical but the personal, so to say, to rip off the tagline for our podcast. But thank you, Kevin, for doing that.
Yeah, Kevin's been doing that for a lot of years, and he has maintained a great effort, and it really shows. Those are always super fun to read, along with timing for improvement. And this article, I think, even said 3 weeks is the average,
Yep.
and that is again longer than some of us might expect. A friend had was emailing me yesterday morning and just was really uncomfortable with the veins and had previously had an injection. I wasn't available because I was in school, so I sent her to one of our partners. She got an injection and was sort of, mentioned that, yeah, occasionally people have flares where they have more pain. And what was interesting was that started 6 hours after the injection and was miserable from a very reasonable person. It was miserable. And I gave the standard counseling, we think ice helps. I definitely would take anti-inflammatories. This will pass, but I can't tell you when. I hope you wake up tomorrow morning and feel great, but it could last 48 hours.
Yeah, those are rough. And I know that we did a nice paper out of here before I got here. The group from here did a really nice paper looking at the frequency of flare reactions. And it's not 100% clearly, and it's usually, I think 20-30%, but I usually tell everybody they're going to get a flare just in case.
Yeah, I absolutely warn every patient, and if it doesn't happen, even better, even better. So we have I believe one last email, which I think was super interesting and really helpful. I'll start with it because
Yeah, well, before we do that, I would love you to take the lead on this, but I would love to shout out our sponsor, Checkpoint Surgical. So please join our sponsor, Checkpoint, at the Hand Society meeting in Minneapolis in September. They will host an industry forum on September 20th at 12:15 p.m., where Dr. Amy Moore and Matt Wood, PhD, will review key foundational studies and current translation of research into therapeutic use of electrical stimulation to accelerate nerve regeneration.
they will discuss new advancements in the field and ongoing clinical research efforts aimed at bringing this novel therapy into clinical practice. You can register on ASSH website or stop by their booth number 419 to learn more about the session and the exciting things going on at Checkpoint.
Yeah,
Excellent.
there is some great stuff going on. We were fortunate enough, David Bergen and I, to be part of the one of the centers in Dr. Moore's prospective cohort or RCT on electrical stimulation intraoperatively for patients with advanced cubital tunnel syndrome. And we now have our own prospective cohort of patients who are undergoing therapeutic brief electrical stimulation for traumatic nerve injury. So we're excited about that and wanted to thank Checkpoint for supporting that last effort for us. So yeah, there's really cool stuff going on. I think Amy and Matt will give a great presentation, so go check that out.
Absolutely. So our final email is from Long Beach, California, and I apologize if I mispronounce your name, but the director there is Karash Kolahi. And I don't believe I've had the pleasure of meeting Karash in person, but I look forward to it. So I'll read his email and then we can discuss his excellent point. First of all, thank you both so much for the time and effort it takes to put together the podcast. Thank you for recognizing that. Um, Parash really appreciates it, and I know other hand surgeons do as well. I think you're doing a great service. I have a minor correction from the recent rock climbing episode that I thought might be of interest. You had referred to pulleys as increasing mechanical advantage by keeping the tendons close to the bone. However, pulleys decrease mechanical advantage for this very reason. Bowstringing, I'm kind of laughing at myself because you and I talk all the time about saying something stupid or being on the record, and we are grateful when people point this out because we're all learning and reminding ourselves. So again, I'll go.
I
You
think
had
I'm
ref
pretty sure I'm the one who said this. So yeah, thank you for the correction, Karash.
Yeah, you had referred to pulleys as increasing mechanical advantage by keeping tendons close to the bone. However, pulleys decrease mechanical advantage for this very reason. Bowstring, although of course not desirable, increases mechanical advantage by increasing the moment arm of the tendon in relation to the axis of the joint. The further the tendon is away from the joint, the more force it can exert on it. Although pulleys decrease mechanical advantage, they provide other more important benefits, including keeping the fingers slender and therefore more versatile and dexterous, increasing range of motion, i.e., getting into a full fist, maintaining a constant mechanical advantage throughout the entire arc of motion, as opposed to a variable mechanical advantage with bowstrung tendons, and therefore control is easier. And then he references Clinical Mechanics of the Hand by Paul Brand and Ann Hollister, which of course is a classic. So really important point, and we can dive deeper if you like.
I think we should. I mean, I agree. I think there are some important pearls in there, and I would love to know how you would respond, given that I think you have far more expertise in this area than I do.
I love how you definitely passed that one on. I don't think either of us would consider ourselves biomechanics experts, but
But I like the exchange, though. I think this is good.
oh,
So,
it's fantastic.
sure there's been other stuff that we've said on the pod where people are scratching their heads saying, "Is that right?" Or that's not what I see. So please continue to let us know.
So, in doing a little research to respond, um, I want to emphasize some of the points that Karash raised. First, um, for power, the greater the moment arm, the greater the leverage or the multiplication factor that translates tendon tension force into the moment resisting external load, such as pinch and grasp force. And so the formula, for those of you who want to geek out on this, is moment equals force times distance, which is the moment arm. And so the example that I found, and I didn't cite this, I apologize, but the example is if the tendon moment arm is 10 millimeters, then 10 millimeters of excursion will yield 60 degrees of joint motion. But if the moment arm increases to 20 millimeters, it takes 20 millimeters of excursion to yield the same 60 degrees of motion. So there is a limit to the degree of excursion that we have to gain motion. And so in addition to this work of flexion, which is probably not the right term exactly, but is increased the greater the moment arm. And so I think the point is that the details of this matter, especially if you're taking exams, and pulleys um, are critical for finger function by decreasing mechanical advantage and decreasing the moment arm.
Yeah. I don't know if there's, I would love to, I remember when I was studying this when I was a resident fellow, really getting into the weeds about work of flexion, which I think is a concept that was popularized very much in the 90s. And I know that I think it was Dr. Mansky here that did a lot of work on work of flexion as well as Dr. Brand. I agree the details are important with regards to test taking, and it is a balance between, providing actual strength, but then leading to excursion in terms of each of the joints. So not focusing on one individual joint, but what the implications are in a pulley system, not looking at things in isolation.
Yeah, and for the younger listeners, when I was in training, certainly I would say the decade of the 90s,
Back in the
the
1900s, when you were
back in the 1900s. The end of the
in the last
1900s,
century,
which is not that long ago. I think you were born.
in the prior
The
century when Chuck was in training.
Well, I was going to say something smart, and now you totally ruined the moment. In the last century, if you had to say what was the predominant research focus, I think we would agree it was absolutely tendon
Yeah.
and, and flexor tendon repair. And two of the leading people in the country happen to be here at WashU, Richard Gelbman and Paul Mansky. Um, and then what's been interesting is and it's a collective although there are certainly those who remain highly interested in flexor tendons, and we are grateful to those people. Our attention has shifted in other directions. And there is no question that at this moment, it's nerve. It's all about nerve.
I think I there's a lot to be said about that. I mean, I think that, Dr. Gelberman had the longest continuously running NIH grant in hand surgery ever for studying flexor tendons. And obviously that grant moved on after he decided to put his jersey in the rafters. So, and we talked before about how he's asked probably each of us to take on the grant, and that was a hard thing to say no to, but tendon was just not my passion. And I think it is nerve for a number of reasons. I don't know how much of that is the clinical topic. It's exciting. People kind of get it. I think the barrier to entry on nerve is lower than on tendon in some ways, both from I don't think from a basic science perspective, but from a clinical perspective. I think it's something that we just see a whole lot, and it's the results are variable enough clinically, where you can clearly see there are gaps in what we understand from a basic perspective, from a surgical perspective, and from a rehab and psychosocial perspective. And that's coming from somebody who, I mean, I obviously have dedicated my career to this. And I don't know how much of it is also like the people who decide to do some of these things. Is it the interest of the people that are chasing grants and big kind of projects like Could that you and Lindley are doing? I mean, is it the people who are influencing the interest as opposed to the topics themselves? Because I mean, basically, you're a hand surgery influencer, Chuck, with your work in adolescent and pediatrics and sports, and maybe they're listeners younger than us saying, "Hey, I want to be like Chuck Goldfarb."
Yeah, I don't think anybody's saying that. It is
It's like no, it
interesting.
used to be like Mike, and it's like Chuck.
The, we were talking recently in our group about how rare scapholinic ligaments are. And you just don't see that many injuries. And therefore, it's hard to for me, to get too excited about the research. To your point, the clinical application is just harder, and it's harder to find patients to follow over time, which emphasizes the importance of working collaboratively at different centers. But that was also the problem with flexor tendons, and we just don't see that many flexor tendons as well, despite being a major center that gets many, many referrals. Of course, my passion really is congenital, has the same limitations. Now, patients with congenital anomalies often will travel, whereas nerve injuries and flexor tendon injuries and ligament injuries less commonly do so, but the numbers just aren't there, which brings us back to your point, which was well said. Nerve injuries are everywhere, and they are quite common. They vary tremendously in location and the mechanism and combined injuries. But I think that is a big contributor. And for whatever reason, it is hot at the moment, and I expect it'll stay that way for a while.
For whatever reason. You just clearly elucidated all the reasons why it's hot.
I still don't understand, nor am I passionate like you.
It's okay. You can just send them to David and me. It's okay. Just go ahead. We've got research stuff going on. So I think before we bring it to a close, I think you've got to run off to school and I've got to get some breakfast ready for the kiddos. We should talk about what we're each doing at the Hand Society. I know that both of us are very excited to join David Way on the podcast that Hand P is doing, and so we'll end up hopefully releasing that as a bonus episode for our listenership as well.
Yeah, so that is a great point. David and I talked a long time ago, and I am really happy with what he has led for the Business of Hand Surgery podcast. And I think they're doing a great job for those of you who hadn't seen it. We don't consider it competition. It's just another hand surgery podcast, which is super interesting. Yeah, it's the other interesting, I hate to overuse that word. The other interesting thing about this meeting is the organizers who have done a wonderful job, did try to limit the number of presentations or involvement for individuals, which is fantastic. It's better for everyone. There's new people on the podium. And so I have a great week, but it's not overwhelming. What about you?
Yeah, no, I think that Nina Sue, a friend of mine, and Eric Wagner, also a friend, have done an amazing job putting this together. And it's hard to follow Paige and Megan, and they've done a great job. And I agree with. I think the focus on limiting commitments for each speaker has started with Paige and Megan, and I think they've done it really well this year, doing the same thing. Because I remember it was like 2 or 3 meetings ago, and it's a combination of my inability to say no as well as my procrastination literally just nonstop for 4 days because I didn't make my slides in time. So I was either talking or in the speaker ready room or meeting with people, and just it was exhausting. It was a sprint. I survived, but it was a sprint. And I have some talks to give. They're talks that I'm really excited about, and I know I was pulled off of some other things. So sort of thankful for that. Although I do love, obviously getting out there and talking about our experience here in St. Louis. So yeah, no, I think for me, the week is starting with being a speaker at the Young Surgeons Boot Camp. So hopefully, I think there might still be some slots available. It's really, really economically priced well. I think it's under $100. And I'll be talking about metacarpal and proximal phalanx fractures, which will be fun. And our one of our partners, David Bergen, will also be a table instructor there for one of the implant companies. So I'm excited to join that.
Awesome. Um, so I have a lot of council obligations, which will take up some time and actually prevents me from participating in the congenital pre-course that Lindley Wall and Deb Bone are running, which is unfortunate because I'd like to go and learn. But my first presentation is on distal radius fractures at pre-course 13 from tomorrow. So that will be tomorrow Rosendahl. That will be great. And I'll briefly run through a couple other things. And then I have a pediatric elbow ICL, which I think will be wonderful as well. Um, we were fortunate to be awarded the Linshai Dobbins Excellence in Wrist Award last year, which leads to an ICL the following year. This is our work on inter-observer reliability for identifying TFCC tears. And so that ICL I'm excited about. And then I close out the week with a dissection.
Yeah, sold out dissection, sold out dissection. Can't get a ticket. Sorry, you might be able to scalp it. StubHub, you might be look at some other resources.
How do you know
Stand
it's sold
outside,
out?
stand outside and look wanton. It's sold out on the website. I was checking you out, man. I was looking at the program.
So it's all six people signed up. That's
Hey,
awesome.
it's all that matters is that it's sold out, Chuck.
Anyways, I'm going to do a pulsation, which is amazing. Obviously, it'll be an adult cadaver arm, but I think we can reproduce the mechanism of that process. And so, looking forward to that on Saturday afternoon. Tell
This
me
is
more
a really
about your,
this is
huh?
a really cool session that they're doing. I
Yeah.
think this series is really cool. I think that Eric and Nina have put a lot of thought into how to structure various types of sessions to get people both kind of the big auditorium style learning, but then also the intimate kind of surgical dissection and pearls and tips and tricks that you get only when you're next to somebody in the OR or in a cadaver lab. So they've got a number of these, my time with the masters sessions, and I think it was an appropriate choice to have Chuck do that session. So that's super exciting. Shout out to one of our partners, David Brogan. He's got the number one spot in terms of podium presentations, so he'll be in the top five leading off.
Not
So
his,
proudly representing our group,
absolutely not his first time in the
and
top
not his
five.
first time in the top five. Very impressive that guy Brogan. I'm glad we brought him over. Uh, and then I'm chairing a pre-course on brachial plexus. I'm super excited, especially because I don't have to give a talk. I'm just chairing. That's the amazing part about being a co-chair is that you can decide whether you're giving a talk or not. And I'm honestly I did that because I figured somebody would back out at some point, and I would have to sub in. So I still might have to do that. But Macy Stoner, our friend of the pod and our frequent guest, is going to be giving a great talk about the rehab and psychosocial considerations for brachial plexus patients, in addition to a star-studded all-star international lineup of speakers. So I think it's going to be awesome. You might be able to get a ticket still. You talk to me, I could probably find a way to get you in. But no, I think that's going to be super fun. And then I've got some stuff on Saturday morning. I've got a presentation to give on Saturday morning about some of the psychosocial and considerations for patients with nerve injuries. So that'll be fun. Brent George from UVA invited me to be part of a really cool ICL. So excited about that. And we've got our WashU hand reception. It's going to be really nice to see everybody from residency and fellowship in the past. And that'll be Friday night with the rest of the hand club meetings.
Yeah, looking forward to that. It has gotten better and better each year. Under your leadership, it has grown and it is a place to be. We even occasionally have friends come by that aren't related or, have no relation to the fellowship. But I really do look forward to seeing everyone. And I'm looking forward to the hand study. And Minneapolis is a great town, be a great time of year to be there. It's pretty easy for us personally to get there. So checking all the boxes.
Yeah, absolutely. I've done a lot of research on the culinary situation. Got a hand therapist I work with down in our South County office. Lizzie Westland is from Minneapolis, so that has helped my selections as well as probably too much online research. So looking forward to it. It'll be very good calorically as well.
God, I mean, that's the fundamental difference between us, at least one of them. I haven't thought about food in Minneapolis
Okay,
once.
one question for you. So anybody listening who knows Minneapolis food knows that they are famous for one thing. Do you know what the Minneapolis cuisine is famous for?
Cheese curds?
No, close though. Close. It's called a Juicy Lucy. It
What is
is
that?
it is a thick burger with the cheese on the inside,
Oh,
uh,
God.
which I have not had yet, and I'm pretty sure it might just be like on the way to the airport, so I don't feel gross the whole week.
Yeah, that you may pay the price on the airplane though.
But former presidents have eaten and gotten a Juicy Lucy at the originator. I believe it's Matt's Bar. So I mean, it's one of those things where you're probably somebody on the campaign tours trying to look folksy and relatable, and goes and gets the cardiac platter. So anyway, looking forward to it. If you're at the Hand Society meeting in Minneapolis, please come up and tell Chuck and I about what you want to hear on the podcast. As you know, you're probably going to have to get in line to talk to Chuck because there's a lot of people that want to talk to him. But you
I
just come up to me whenever. I mean, I'm a pretty casual guy. So,
love it. All right. Well, this was fun and have a good day.
all right, you two, take care.